Good evening. Today I'll be talking about a role of personalized medicine in the field of endocrinology and metabolism. We know that type 2 diabetes mellitus has become a global epidemic. By 2030, around more than 400 million people will be affected with type 2 diabetes mellitus. And though there are multiple options for the management, the outcome is not optimum. It is because we know that type 2 diabetes mellitus is interactions is a resultant of interactions between environment and genes, and so the management is also going to be affected by multiple factors, not only the lifestyle associated factors, but may be also related to the genes underlying the causation of the particular diabetes. We know that a particular drug can be effective in a particular patient because of the genetic mutations and may be resistant to the molecule also. And not only that, a particular agent or particular drug may have some non-glycemic actions, meaning they may have some actions beyond their glucose lowering capacity, which may be helpful in terms of reductions of cardiovascular mortality or morbidity. For an example, a patient who is having multiple coronary risk factors, or who is having established atherosclerotic vascular disease like coronary artery disease, might be benefited from a particular group of agents such as GLP-1 receptor analog or SGLT2 inhibitor. On the other hand, those who are not having those established coronary artery disease or established vascular diseases may not be needing, may simply be treated with other available agents. In other areas of endocrinology, we often find families of inherited disorders like multiple endocrine neoplasia, where different types of endocrine cancers or malignancies may occur. In that cases, we screen the members of the family by doing particular genetic tests, and we can prevent the development of cancer by taking some actions in the form of surgery or medications preemptively. So there used to be a time when we used to say it clinical medicine, when most of our treatment protocol or management were dependent mostly on our clinical judgment. Then we shifted to evidence-based medicine or internal medicine. We gathered evidence, and we tried to channelize our focus or pinpoint our treatment by gathering evidences. And now we are trying to we're trying to tune it more finely by by using genetics and other available laboratory parameters, which is known as personalized medicine, so that a person can get benefited mostly by a particular agent without having much of the risk factors. Thank you.